Hi, Brian Kaufman here on the Monday afternoon at ASH 2018 as the Chief Medical Officer at the CLL Society.
And I'm Victor Hofbrand, Emeritus Professor of Hematology from University College London.
Professor Hofbrand, you've been working in hematology for over 5 decades, and you've seen tremendous change in how we diagnose, manage, treat all aspects of several diseases. But I'd like you to focus in on chronic lymphocytic leukemia and what you've seen and kind of what your impressions, and if you could sort of share that in a patient-friendly way so patients could understand what you've seen evolve.
Yes. When I started in hematology over 50 years ago, chronic lymphocytic leukemia was a rather silent disease. At that time, most patients presented with some symptoms of the disease, but once one analysed the cells, we knew very little about it because we couldn't get, the cells are non-dividing, we couldn't get chromosome analysis. Of course, there was no molecular biology to investigate the cells in more detail.
And so when they say they had symptoms, was it lymph nodes or what are B symptoms?
The symptoms. Why I mention patients presenting with symptoms is nowadays, 50 years later, most patients present because they're picked up without symptoms, right, but on a chance blood film. In those days, it was about 10% of our patients were picked up by chance. Now it's 10% of our patients present with any symptoms at all.
Right.
The symptoms of lymph nodes, infections, the sort of typical symptoms of
more advanced disease.
Advanced disease. So that's because more people have routine blood counts for insurance purposes, for health checks, and many people, maybe it's a problem of picking up so many people, because if they don't know they've got a very indolent condition, perhaps it's better they don't know, because people are transformed overnight from a normal to somebody who's got leukemia.
Right.
And
right.
I think that's a very dangerous situation. Some people then think that it's they're extremely ill, when in fact their life expectancy may be not affected by the diagnosis, particularly in women with low count and picked up routinely. In females, the life expectancy may be entirely normal.
And that's already a significant change you've seen in your career in terms of when it's diagnosed.
Exactly. The change in classifying the disease according to prognosis, which we now do with complicated antibody tests, chromosome analyses, which we can do now, molecular genetics of the condition. We can classify each person at diagnosis into a prognosis. The importance of that is obviously more information for the patient, but it's also guides our treatment, because if you've got a very good prognosis condition, you may not even treat at all unless there are quite severe symptoms. But if you've got, initially you've got a bad prognosis condition, then you want to bring out your strongest therapy. Now, 50 years ago, our strongest therapy was basically one of 2 drugs, chlorambucil or cyclophosphamide, alkylating drugs. In those days, it was very much single agent therapy. And
did you use steroids to treat it?
Yes, but mainly for people with complications such as an immune hemolytic anemia, low platelets. The steroids were double-edged because they could treat it partly, but they increase the risk of infections and they have side effects if you use them chronically. So the main standard of treatment was controlling the lymphocyte count, shrinking the lymph nodes with chlorambucil or cyclophosphamide. In those days, there were discussions of whether to use 2 drugs together, even if there were 2 drugs. A lot of people said that was a bad thing. You could keep one drug in reserve, and when the person became resistant to the first drug, you come in with the second drug. Fairly soon after that, combination treatments using 2 drugs at once came in. Initially, I think for Hodgkin's disease, in which DeVita showed that using 3 or 4 drugs together gave much better results than keep using one individually, and when someone became resistant, using the next one and then the next one in series. So combination treatment came in, but for CLL it took quite some time before there was anything to combine.
Okay.
The new drugs in the more modern era are fludarabine, rituximab, an antibody, and even more recently, of course, ibrutinib. But these have come in the last 2 decades. Ibrutinib in the most recent decade. We didn't have those choices through the 60s, possibly even in the 70s.
Right. Wasn't there famously a study that looked at early intervention in CLL that showed that patients didn't do any better and maybe a touch worse if you
Yes.
gave them chlorambucil before they needed it?
Absolutely. This was the problem of diagnosing people with no symptoms, and then because they'd got a leukemia, treating them. But the trial showed it was better to leave the condition untreated if the patient was well and symptomless, rather than exposing them to an alkylating agent with possible complications of low white cell count and infections, possibly even late complications of being exposed to an alkylating drug.
And that's where the whole watch and wait or active observation came
Yes.
from, which for patients is such a cognitive disconnect because I've got cancer, aren't you going to treat me?
Yeah.
And we have to turn to them and say, but there's no evidence that it helps treating you early.
Yes, yes. I think my O's argument, yes, we have to treat you rather than your blood count.
Right.
We're not treating a blood count, we're treating a person. We're doing what's best for the person. I mean, people can have, with CLL, can have counts of over 100,000 with no symptoms.
Right.
I've seen someone with a count of 400,000 and no symptoms.
Right. Yeah, you treat
And
the
so
patient, not the lab test. Yeah.
It's a patient who, if the person is not anemic, has got enough normal white cells to protect from infection, and is symptomless, then the treatment for a good prognosis case based on other risk factors could well be watch and wait, even with a high count.
Absolutely.
It depends partly whether the count is stationary or doubling every few months.
Right.
If it's if the count is changing, particularly if in addition the shall we say the flowers in the blood, the hemoglobin, the platelets, the neutrophils, if they're dropping, and the weeds, the lymphocytes, are taking over.
I like the analogy. I like
then
that, yeah.
you want to rescue the situation before you lose all your flowers.
Right.
And kill the weeds. But if they're living in side by side, it may be better to leave them. And if you've got enough flowers, then it doesn't matter if you've got a few weeds around.
So let me ask you your take on the new targeted therapies. We're seeing ibrutinib, venetoclax. We saw these first in CML, where they first began. We had first targeted therapies. This must be from your perspective, this must be a tremendous revolution and exciting thing to see in your career as a hematologist, to see how medicine has become so much more precision.
Yes, it's tremendous. I mean, towards the end of when I was seeing patients, for patients with the chromosome change 17p, the outlook was very poor, and all we could offer them was a monoclonal antibody, alemtuzumab, anti-CD52.
Campath.
Yeah. But the problem with that was it led to serious infections. It was blunderbuss killing the immune system, and though it could get the condition under control, the risk to the patient was very substantial of viral and other infections. So the beauty of ibrutinib is that it's much more specific, and that it is active against 17p deleted CLL and other resistant cases. So it's an amazing improvement alone, and the question is now of different combinations. Venetoclax is a very active drug against a variety of diseases, as you know, not just CLL. Again, these new drugs are tested initially on patients who are resistant to other drugs, who have relapsed on other treatments. But gradually the tests are using these drugs up front, at least for younger patients, to see whether if you put all your best drugs up front, you're going to get very long remissions, hopefully cures. But the new drugs gradually work through from being used in the most difficult patients to be used up front. Of course, in older patients presenting with CLL, then one's got to be very careful to, again, match the drugs with the patient. You haven't got to be too immunosuppressive, and particularly older people more susceptible to infections, pneumonia, this sort of problem, and that you've got to balance against the efficacy of the drugs. So enormous trials are needed to see what's best for everybody, older people, younger people, people with good prognosis condition, poor prognosis condition. But there's no doubt that the overall outlook for a new patient now with CLL is incredibly better than it was when I started.
I say to people, there's never a good time to have CLL, but there's never been a better time to have CLL than now.
Yeah. Well, I think the two game changers were the combination of fludarabine, FCR, cyclophosphamide, and rituximab.
Right.
That was the first, getting over 50% of patients into what's a very good remission with the first line therapy. And the second game changer is ibrutinib. Right. And now there's a second generation brutinib, acalabrutinib.
And I think the next game changer is going to be combinations of these targeted therapies and maybe fixed duration that we'll be looking at for non-chemo drugs.
I think so. The drugs I used, chlorambucil cyclophosphamide, becoming a little bit obsolete, but not entirely. Chlorambucil has made a bit of a comeback in combination with not rituximab particularly, but with obinutuzumab,
right,
a similar antibody.
Right,
and
but
that,
more potent.
Yes, and well, it seems to be for CLL.
Right. And
for older patients, the combination of obinutuzumab and chlorambucil seems very effective, putting some people into what seems to be complete remission. You can hardly detect the disease. And then you can keep for them ibrutinib in reserve.
Are there any other thoughts that you'd want to share with patients about what you've seen in the evolution of the management of CLL over the last 50 plus years?
I think that the choice, the big change is choice of who should have treatment initially, who should start on treatment.
I totally agree with that.
Is much more precise and informed and evidence-based than it was. I think the choice of treatment, again, is being based on evidence of the different combinations and up front. I think the outlook for people who relapse after first-line therapy is incredibly better than it used to be. We had hardly anything to offer them other than Campath, and now all the new drugs, and presumably there are new drugs in the third generation,
right,
ibrutinibs, and so the outlook is incredibly better. I mean, one thing that possibly has gone out of fashion is doing bone marrow transplants for chronic lymphocytic leukemia, because that was a sort of way of trying to cure the very resistant cases, failed everything else, so we'd do a bone marrow transplant, which is a risky procedure. And I think the indications for that have diminished because the new almost non-chemotherapy drugs are so effective that they've much safer, shall I say, than bone marrow transplants. And on the whole, the chronic lymphocytic leukemia patients are in the older age group, which who don't do as well with bone marrow transplantation as younger people.
So if you bring up one cellular therapy, I have to ask you about the other exciting cellular therapy, CAR T therapy.
Yeah.
And what are your thoughts in terms of that, to see a gene therapy develop during your career?
Yeah. Well, I think it's clearly a terrific treatment for very resistant cases, life-saving. I'm a bit concerned about the costs.
Yeah.
Whether health budgets can afford this individually very expensive therapy, and for how many patients will the health budgets match? Certainly in underdeveloped countries, it's going to be very difficult to introduce CAR therapy because of the costs. In developed countries like the United States, presumably the CAR therapy will be funded, but I think there's going to have to be quite a lot of discussion between health boards and government of how much money can be allocated. But it's a remarkable change that in a way we're moving almost out of a chemotherapy era to an immunotherapy, targeted drugs therapy era. That the old blunderbuss chemotherapy that killed both the weeds and the flowers is becoming almost of the past, and now we're just using combinations that kill the weeds and leave the flowers alone.
Professor Hofbrand, it's so great to get your perspective. Thank you so much for all you've done over your career, for not just CLL patients, but all hematology patients. Yeah.
Thank you very much. Yes, I do write about CLL in my textbook, so I have to keep reasonably up to date,
Right.
even though I'm not seeing patients now.
Right. All right. Thanks so much.
Thank you.
Thanks.